Good morning, everyone. My name is Alicia Mins. I'm a toxicologist in San Diego, and today I'm going to be talking to you about derm principles, dermatologic principles. So as an ER doctor, we have a very, or at least personally, I have a very simple algorithm for dealing with rashes, whether it's itchy or painful. But when it comes to toxicologic causes of skin disorders, it's far more complicated than that. So today I'm going to be talking to you about dermatologic toxicity. And first we're going to go over skin anatomy, which is important to understand some basics of skin anatomy, just to understand sort of the physiologic basis for some of the diseases that I'm going to talk about. We're going to talk about topical toxicity, dermatologic signs of systemic disease, drug reactions, and then historical examples, which definitely come into play in terms of the board testing. So just in terms of an introduction, the skin is the body's largest organ, weighing 7% of body weight and measuring about 2 meters squared. The skin serves as a protective barrier against harmful substances. It's involved in thermoregulation, it's a sensory organ, and has immune system functions. The skin primarily consists of 3 layers: the epidermis, dermis, and the subcutaneous fat. The poison center gets about 7% of calls to U.S. poison centers involve dermatologic exposures, and about 1% of fatalities are reported to be from some sort of dermatologic cause. So let's first talk about skin anatomy, going from top to bottom, and I'll try to make this simple, relevant, and give you some clinical examples as well. So the skin has 3 main components that interconnect anatomically and functionally: the epidermis, dermis, or the subcutis, or the hypodermis. The primary role of the epidermis is to serve as a barrier, maintain fluid balance, and prevent infection. The degree of barrier function varies with the thickness of the epidermis, which ranges from anywhere from 1.5 millimeters on the palms and soles to 0.1 millimeter on the eyelids. The epidermis itself is composed of 5 layers, including the basement membrane, with the stratum corneum being mainly responsible for the physical barrier function of the skin. This layer is made up of keratinocytes, and disorders of either proliferation or desquamation can lead to inadequate barrier function. Here's an example of hyperkeratosis due to arsenic poisoning. And you can see the thickened skin on the palms and soles, or the palms in this situation, which, although you can think the skin is thicker, there's cracks in the skin, and that this can actually lead to decreased barrier function of the skin. The stratum corneum is actually covered by a surface film composed of something called sebum, which is really just a mixture of sweat and breakdown products of keratinocytes. This functions as an external barrier to protect from entry of bacteria, viruses, and fungi. There's another layer of protection, which are lipids called ceramides. And then diseases characterized really by dry skin, such as atopic dermatitis, which I'm showing you here on the right-hand screen, as well as psoriasis, which is the bottom picture, have decreased ceramides in the stratum corneum, which allows for greater drug penetration. So you think of anything that you're going to put topically on your skin, if you have decreased barrier function, there's a risk for increased absorption of that drug due to the decreased barrier function. An example would be hydrocarbon solvents. These are alcohols, detergents, hydrocarbons, and they can produce something called a defatting dermatitis, and this is from dissolution of these surface lipids. Here's an example here of defatting dermatitis. This is a 24-year-old female who presented to the emergency department after experiencing a cardiac arrest. She was found unresponsive. She had a plastic bag sealed around her head. She had return of spontaneous circulation after about 12 minutes of CPR, and she was noted to have this facial erythema. And here you can see a clear demarcation below the angle of her mandible where the plastic bag actually had been secured. The erythema progressed over the next 24 hours, and she had this associated blistering edema and then patchy desquamation of her skin, her wounds were treated with topical antibiotics and then consultation with plastic surgery. So here is an extreme example of a defatting dermatitis. So sort of moving further down, the cells in the basal layer renew the epidermis. They actually contain stem cells that migrate to the surface and become the keratin, and this process takes about 28 days. The basal layer is just above the basement membrane and has both melanocytes and Langerhans cells. You guys probably know melanocytes are responsible for absorbing UV light and produce skin pigmentation. Langerhans cells are bone marrow cells, and they're derived from dendritic cells, and they're actually responsible for immunosurveillance. The basement membrane is very important because it's actually the target of genetic defects as well as autoimmune diseases, which attack this area, leading to a variety of inherited as well as acquired skin diseases. Here are some examples here. So to the left, this is bullous pemphigoid, which is an autoimmune pruritic skin disease, preferentially in elderly people, that forms these blisters and bullae at the space between the epidermis and dermis skin layers. And this is actually a type 2 hypersensitivity reaction. And then to the right is a disease called epidermolysis bullosa, which is actually an inherited disorder that leads to skin blistering. And these are disorders that both involve the basement membrane that we had just talked about. So here is a busy slide that you can see, but the reason why I want to show this slide is just to give you an idea of the numerous blistering or bullous diseases there are, both acquired or inherited, some drug-induced, some not. Most of them look very clinically similar, and oftentimes a diagnosis cannot be made until a biopsy is actually performed. And you can see these arrows here really just pointing to where in the skin layer, specifically the epidermis, that you start to see problems and where these diseases arise from. So let's keep moving further down. The next we're going to talk about is the dermal-epidermal junction, which provides resistance from trauma and gives support to overlying structures. The dermis below the dermal epidermal junction contains adnexal structures, so this is your blood vessels and your nerves. The dermis provides structural integrity and contains collagen and elastin embedded in chondroitin A and hyaluronic acid. Most people have heard of those terms because those are actually contained in many sort of skin creams that target aging. And the dermis also contains sweat glands. Your skin actually has two types of sweat glands. You have your eccrine glands and your apocrine glands. The eccrine glands are over most of your body and open directly onto the surface of your skin. The apocrine glands open into a hair follicle, and this leads to the surface of your skin. And apocrine glands, because they're around hair follicles, develop in areas that are abundant in hair follicles, such as your scalp, your armpits, as well as your groin. Now, certain anti-neoplastic agents, specifically cytarabine and bleomycin, directly damage the eccrine glands, and this leads to a condition called anhidrosis. This is also an area where you get acne. So sebaceous glands also reside in the dermis, and they produce an oily, lipid-rich secretion that functions as an emollient for your hair and your skin, and can also be a reservoir for drugs. You can see here several examples of drugs that are associated with acne. Probably the most famous example is something called chloracne. Certain halogenated aromatic chemicals, such as polychlorinated bipheноls, PCBs, dioxin, and 2,4-dichlorophenoxyacetic acid, are excreted in the sebum and cause hyperkeratosis of the follicular canal. This produces the syndrome chloracne, which really looks like severe acne, but predominates in the malar, so your retroauricular and mandibular regions of the head and neck, and will develop weeks after exposure. Similar syndromes have also resulted from exposure to brominated and iodinated compounds. This is Viktor Yushchenko, who was poisoned with dioxin. Certain skin lesions may also be a result from exposure to brominated and iodinated compounds, and this is called broderma or ioderma. The picture to your left is a female who was abusing a sleep aid called Naronance from Japan. that contains bromovaluria. She had a significant elevated bromide and chloride level and a negative anion gap, which is very classic for bromide toxicity. And then the picture to your right is a 5-month-old who is getting a daily colic medication that contained calcium bromide. The half-life of bromide is about 2 weeks, so it takes a while for the lesions to resolve once the drug is removed. Now, bromide is very interesting. It's been used medicinally for decades. Bromides are divided into 2 types. There's inorganic as well as organic agents. The inorganic agents, such as potassium bromide and sodium bromide, are used mainly for the treatment of epilepsy. And then the organic agents were previously popular as sedative hypnotics. These medical bromides were widely used in the late 19th and early 20th century, and many cases of intoxication or bromism and bromoderma were reported during that period of time. Now, after the advent of barbiturates and benzos, bromides quickly fell into disuse for the treatment of epilepsy. And in addition, due to side effects and severe intoxication, the U.S. Food and Drug Administration recommended that bromides should not be used for the treatment of any disease. Bromide salts were removed from all over-the-counter products in 1975, and organic bromides were removed from OTC sleep aids as well. Now, bromoderma now is rarely seen in the United States. However, Japan, and there are several other varieties. In Japan, there are several other varieties of analgesics and sleep aids that still contain bromide is available as OTC medications. So something that's probably seen more often in other countries. So moving further down, and we're sort of getting to the end of the anatomy portion here, the hair follicle is part of the skin, and it's divided into 3 portions. The deepest portion contains the bulb here, as well as the matrix cells, which are very mitotically active and really often the site of many cytotoxic drugs. The rate and growth and type of hair are different for different body sites. So you can imagine the hair on your scalp grows faster than hair on other parts of the body. And hair growth goes through 3 phases. The length of the anagen phase, which is really the active growth phase, determines the final length of hair and varies depending on the side of the body. For example, hair on the scalp has the longest anagen phase, ranging anywhere from 2 to 6 years, with hair growth occurring around 0.4 millimeters per day. Now, hair growth can be used to identify certain clues regarding the time and mechanism of action of a drug. Drugs can be divided into telogen effluvium and anagen effluvium. Telogen effluvium is a scalp disorder characterized by thinning or shedding of hair, resulting from early entry of hair into the telogen phase, which is the resting hair phase of the hair follicle. In this phase, that telogen hairs begin to shed at an increased rate, which are normally the appropriate rate of hair loss, is about 125 hairs per day. So this is a scalp of someone with arsenic poisoning. Now with telogen effluvium, you can see more diffuse thinning of the hair. And here are some other examples I have listed here in this box of drugs associated with telogen effluvium. Anagen effluvium is the pathologic loss of anagen or growth phase hairs. Classically, this is caused by radiation therapy to the head and systemic chemotherapy, especially with the alkylating agents. This is a patient here in this picture who has alopecia after intestinal ingestion of a natural occurring colchicine. The patient is shown at 9 days after poisoning with onset of hair loss. This is 11 days, and this is 14 days, demonstrating both loss of scalp as well as axillary hair here. And you can see a lot of the metals too can cause anagen effluvium. And then sort of lastly, we talk about the nail plate, which is often considered analogous to the hair and also continuously grows. Fingernails grow at about 2 to 3 millimeters per month, and toenails about 1 millimeter per month. The mitotically active cells of the nail matrix down in here that produce the nail plate are subject to both trauma and drug injury, which affects the appearance. Now, because the nail growth is stable, location of the abnormality in the plate can actually predict the timing of exposure. So Mies lines are here depicted here on this side, which are white and they're not grooved. And these are called Bose lines, which are deep grooves within the nail plate. And you can see I've listed some examples of drugs that are associated with both mesalines and bowlines. This is just my transition slide. This is actually my daughter who had hand, foot, and mouth a couple of years ago, and this was her rash, which was pretty nasty looking, but didn't seem to be painful. This is commonly caused by Coxsackie, spread throughout preschools. So anyway, let's move on to the topic of transdermal drug absorption. So there's no active uptake mechanism for drugs by the skin. However, many undergo percutaneous absorption by passive diffusion. Lipid solubility, concentration gradient, the molecular weight, and certain skin characteristics are important dominants of dermal absorption. Absorption is determined to a great extent by the lipid solubility of the drug. Now, with any route of administration, adverse effects and toxicity can be caused by excessive absorption after patch application. And the common patch drugs that we talk about are nicotine, fentanyl, nonsteroidals, as well as lidocaine. Now, other drugs applied topically without a specific delivery device include podophyllin, camphor, phenol, organic phosphorus, ethanol, organochlorines, nitrates, and hexachlorophene. And these are all associated with systemic toxicity as well as mortality. Quick question here. Prior to its removal in 1972, the bathing of newborn infants in this led to the development of vacuolar encephalopathy. And this is hexachlorophene. Silver sulfadiazine cream applied to burn patients containing this contaminant led to renal failure and neuropathy. This was reported in several different mass outbreaks, but the one specifically here in Spain was diethylene glycol, and it was added as a substitute within the sulfur sulfadiazine, and it was applied to burn patients who had extensive areas of skin breakdown, and it led to systemic absorption of diethylene glycol. So let's talk about a bit about burns. So exposure to a variety of industrial and environmental chemicals can cause dermal burns. Although the majority of these cause injury via a chemical reactivity rather than thermal damage, the clinical appearance really looks the same. Often an injury may appear mild and superficial, and then it can progress over the next 24 to 48 hours. Now, both inorganic and organic acids penetrate the epidermis via protein denaturation and cytotoxicity. However, the damaged tissue coagulates and forms a thin eschar that limits the spread of the chemical. This is called coagulative necrosis. You can see examples here. Hydrochloric and sulfuric acid are probably the big ones. Alkali exposures will produce a liquefactive necrosis by disrupting barrier lipids and saponification, and cutaneous injury is typically more severe than that of an acid. And here are some examples here: sodium, ammonium, potassium hydroxide, sodium potassium carbonate, and then calcium oxide. Thermal damage can actually also be the result of a drug or chemical. For example, as we've already briefly discussed, an exothermic reaction can occur from wetting of elemental phosphorus or sodium. Also, skin exposure to a rapidly expanding gas, such as nitrous oxide and whippets, or frozen substances, such as dry ice, can produce a freezing injury. This is a picture involving a 40-year-old female and her 7-year-old daughter who were collecting rocks on a beach in Tel Aviv. After returning home, the daughter washed the rocks of sand with tap water and immediately wrapped them in a paper towel. The daughter presented her mother with an unusual appearing yellow translucent colored rock covered by a wet paper towel. And she commented, when she started to unwrap the paper towel, white smoke started to emanate from the rock and then ignited with flames, accompanied by severe burning sensation of her hands. She dropped the rock, it hit her calf, and then it basically caused a fire in their apartment. They were safely evacuated and brought to the hospital. And this ended up being white phosphorus, which is very fat soluble, and it can lead to necrosis of the kidney or liver, and it can produce multiple different physiologic alterations, including hypocalcemia, hyperphosphatemia. You can have resultant EKG changes as well, and even a small burn, such as 10 to 15% total body surface area, can actually cause a sudden or unexpected death with white phosphorus. So that's an example of a interesting burn. Phosphorus burns are typically very painful and necrotic and yellowish in color with a characteristic smell of garlic. We always talk in toxicology about things that smell. Here's a garlic example. They commonly cause full thickness burns resulting from chemical and thermal insults. And then systemic toxicity really occurs in 3 phases. In the first 8 hours, the patients may experience GI symptoms. And then from 8 hours to about 3 days, they may be asymptomatic. And then after that, they can develop multisystem organ failure and CNS dysfunction. So physicians should definitely be aware of these complications, such as hypocalcemia, hyperphosphatemia, and cardiac dysrhythmias. So in patients who are exposed to white phosphorus. It's really interesting. There's definitely there's been some controversy about how to decontaminate white phosphorus. Certainly thorough irrigation of the wound with saline or water is pivotal, and you got to completely remove the phosphorus particles, which actually can be identified by the use of either copper sulfate or UV light. Copper sulfate actually converts phosphorus to a black film, making the embedded particles more easily visible. However, the use of copper is associated with renal failure and poor outcomes. And so now people recommend that you actually use UV light as depicted here to see the phosphorus particles glow, and then you can debride them as well. Hydrofluoric acid is another interesting compound that we talk about that can cause burns. It's weakly acidic, and it's used for etching of glass, metal, and stone. It actually has limited dissociation content, so it's able to penetrate intact skin with deeper penetration into deeper tissues. The fluoride ion itself is very cytotoxic, and it can cause severe tissue injury as well as bone destruction. And severe pain is caused by the capacity of actually the fluoride ion to bind tissue calcium and affect nerve conduction. The proton itself can cause acid-induced necrosis, and the fluoride ion will cause cytotoxicity. And here's some pictures here of typical hydrofluoric acid burns that don't look that significant initially, but they can be very painful and deep. Here's an example of a patient who had severe hydrofluoric acid burns on his extremities here, and he actually ended up developing necrosis and needing large area skin grafts because of this burn. So just one slide in decontamination. When not to use water, I find this interesting. In general, copious water is really the decontaminant of choice for skin irrigation. Soap can certainly be used if a substance is adherent. There are a few situations where water should not be used. The first one is contamination with reactive metal forms of alkali metals, such as sodium, potassium, lithium, cesium, and rubidium. These react with water to form strong bases. These are your group 1 here on your periodic table. These are the alkali metals. The second situation is dust of pure magnesium, sulfur, and a few other compounds, such as titanium, uranium. They will actually explode on contact with water. So you want to remove any metals with forceps, gauze, towels, and store actually in mineral oil. The third is phenol. It actually becomes thick and hard to remove with water. So the recommendation is to use polyethylene glycol or isopropanol to remove. And then lastly, calcium oxide becomes calcium hydroxide and causes ulcerations. So you actually want to remove it mechanically. Calcium oxide is used in a lot of different compounds, like cement, for example. So moving on, the next topic we're going to talk about is dermatologic signs of systemic disease. So there's a couple different things that make you turn blue, also called cyanosis, as you know, which is the blue or violaceous appearance of the skin, mucous membranes, and nail beds. This can occur with excessive concentrations of reduced hemoglobin, such as in hypoxia or polycythemia, where you have greater than 5 grams per deciliter of reduced hemoglobin. You can also see cyanosis when you have oxidation of the iron moiety in hemoglobin to the ferric state, and this is methemoglobinemia. Also on the differential is an interesting condition called pseudochromhidrosis, which is also called extrinsic apocrine chromhidrosis. And this is actually when you get staining of the sweat, either by bacteria, such as bacillus, topiramate is a drug that's been implicated. And you can actually wipe away the discoloration with a damp swab, which gives you an idea of what it is. Here's some examples of pseudochromhidrosis. Here you see some blue on the left and then yellow on the right. There's also case reports of black, red, and other colors of pseudochromhidrosis. And you can see when it's wiped away, you can see the blue on the pad, and down here, you can see the yellow. Often the etiology is unknown. However, when you look at case reports, these patients are typically treated with antibiotics, as bacteria are the common cause of this condition. Xanthoderma is a yellow or yellow organ discoloration of the skin. The carotenoids are an example. They're excreted in sweat, sebum, urine, and the GI tract. These can also be removed with an alcohol swab. This is differentiated from jaundice, which is from hepatocellular failure or hemolysis, and bilirubin gets deposited in the fat. Now, scleral icterus is present in jaundice, but not from the carotenoids. Lycopenia also occurs from excessive consumption of tomatoes. And then there's other exposures like dinitrophenol and then picric acid, which is used in munitions. And these can all cause xanthoderma. And then skin pigmentation in general can be from a drug being ingested that's carried to the skin by blood or topical applications. Many heavy metals are associated with skin pigmentation. Argyria is a slate discoloration from systemic deposition of silver after excessive ingestion, and this can be either localized or widespread. More prominent in areas exposed to sunlight because silver stimulates melanocyte proliferation. And then gold has historically been used to treat rheumatoid arthritis and also can cause a gray slate pigmentation, often periorbitally called chrysiasis. Bismuth can cause discoloration of the tongue and gums, and then medications such as minocycline and certain psychotropics and chemotherapeutics can also cause skin pigmentation. So here's your classic Argyria patient, and it's more prominent, as you can see, in the areas that are exposed to sunlight because, again, silver stimulates melanocyte proliferation. And then here's your bismuth tongue. So you may see this in someone who is taking too much Pepto-Bismol. So moving on to a fairly large topic that really sort of overlaps with topics that need to be known for emergency medicine are drug reactions and other topics. So the skin is actually one of the most common targets for adverse drug reactions. And there are many different types of drug reactions that can be observed, going from urticaria, moving on to erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis. You can see fixed drug reactions and then drug-induced hypersensitivity reactions. So we'll go over all of these. The urticaria in general, just talk briefly. These are transient pruritic plaques or papules which blanch. They can have a central clearing, which may mimic erythema multiforme. You can see down here as an example. 40% of patients who have urticaria can develop angioedema or anaphylaxis, and this is a type 1 IgE dependent reaction. So everyone sort of has their own chart that they think about when differentiating Stevens-Johnson's TN versus erythema multiforme. This is my simplified chart. You may see various versions of this. You can actually break this down even further into erythema multiforme minor as well as major. There's also a Stevens-Johnson's 10 sort of overlap syndrome that's somewhere in between here. But this is my simplified way of looking at it. Now, erythema multiforme used to exist on the spectrum of Stevens-Johnson syndrome and TEN, but it's really now considered a separate entity, as most cases of EM are triggered by an infection. HSV is the common one implicated. And then Stevens-Johnson syndrome and TEN are most often triggered by medications, although medications can elicit erythema multiforme. Now, the medications that are implicated in TEN are also the ones implicated in erythema multiforme. In general, erythema multiforme is the least severe disease process, and TN is the most severe with the most body surface area affected, really with diffuse epidermal detachment and the longest resolution period. So just talking a little bit more about Stevens-Johnson's and TEN, and here's an example here. There are actually over 200 medications implicated in TEN, and they can be divided into short-term and long-term medications. The most common short-term medications include trimethoprim, sulfamethoxazole, and other sulfonamides, cephalosporins, quinolones, and aminopenicillins. With chronic use, the increased risk mainly occurs in the first 2 months of treatment and was greatest for carbamazepine, phenobarbital, phenytoin, valproic acid, allopurinol, and other certain nonsteroidal drugs. The incidence of TEN is actually higher in patients with advanced HIV. It's been well documented. And then factors that are associated with the poorest prognosis are, not surprisingly, medications with the longest half-life, age, and worsening acidosis, because typically sick people are sicker. The next thing that I'm going to talk about is something called erythroderma, which is also called exfoliative dermatitis. And it's really defined as a generalized redness and scaling of the skin. It's not one specific disease entity, but a presentation of a variety of skin diseases, and at times the underlying etiology has never been found. This is an example of boric acid, which is classically described as that boiled lobster appearance. Now, the toxic effects of boric acid were first documented following its use as a surgical site antiseptic and therapy for burns. There have since been many reports of toxicity and even fatalities resulting from mainly its ingestion, and mostly in infants and young children. And so as a result, boric acid has been largely removed from medical products, although you can still find it in certain ophthalmic preparations, topical disinfectants, many consumer goods, and insecticides. Boric acid poisoning is rarely fatal in adults because you really need a large amount for serious toxicity. But the initial phase of poisoning consists of nonspecific GI symptoms, and then you get this boiled lobster rash, which is an intense generalized erythroderma, manifesting shortly thereafter with extensive desquamation within 1 to 2 days. And then serious effects of borate poisoning include cardiovascular collapse, seizures, and renal failure. The only potential therapy is dialysis or exchange transfusion, which has been anecdotally effective. Can't talk about tox without talking about coma blisters, which we used to call barb blisters. Coma blisters are tense spoli on normal skin that occur within 2 to 3 days of a comatose patient and can be seen with any sedative hypnotic overdose, but it's actually been described in patients with coma from other etiologies, like sepsis or whatever. They're thought to be from pressure-induced epidermal necrosis, but actually can also occur in non-pressure dependent areas, suggesting a systemic mechanism involved. You can see here they're sort of circumferential in this picture. And then drug-induced vasculitis actually accounts for about 10 to 15% of secondary vasculitis. The vasculitis can occur 7 to 21 days after initial exposure or after 3 days of a re-challenge. It's characterized by a non-blanching purpura that becomes raised, and they're palpable, typically in dependent areas, with the exception of levamisole, which we'll talk about in a minute. Histologically, you will see something called a leukocytoclastic vasculitis, which is where you get fibrin deposition in the vessel walls. The vasculitis can be limited to skin, or it can actually involve other organs as well, such as the kidney or lung. And the treatment is really just withdrawal of the drug as well as corticosteroids. So a lot of overlap here in terms of the drugs that can cause vasculitis versus the other drug skin reactions like TN and SJS. Now, levamisole can cause an interesting vasculitis. Levamisole is an anti-helminth agent, and because of its immunomodulatory modulatory properties, it was used to treat autoimmune or systemic conditions, including nephrotic syndrome, RA, and solid tumors. It was, however, withdrawn from the market in 2000 in the United States and Canada in 2003 because of side effects, which include agranulocytosis, vasculitis, and leukoencephalopathy. It's still used by veterinary clinics in the United States and South America, and since 2003, we've seen it used to adulterate cocaine. It reduces the cost of cocaine preparation and increases the release of norepinephrine in peripheral tissues and dopamine in the brain, thereby improving neurotransmission in the CNS and increasing the effects and duration of cocaine. Now, in the United States, levamisole has been detected in 70% of cocaine seized by customs and 88% of urine samples of cocaine users. And then actually in the United Kingdom or Europe, it's actually been higher than that. Now, you will see this syndrome of vasculitis, neutropenia, and this retiform purpura, sort of like a lace-like appearance of the purpura from levamisole adulterated cocaine. And in this condition, for whatever reason, the earlobe is most common, but also the lower extremities. And women are more commonly seen than men. Typically, patients will do okay, however, with just supportive treatment. The next skin disorder I'm going to talk briefly about is the anticoagulant-induced skin necrosis. This is induced by warfarin and more commonly occurs in obese women with an average age of 50. The clinical picture is usually associated with the administration of high-dose anticoagulant doses, and the patients most susceptible to this complication are those with positive lupus anticoagulant, protein CNS, and antithrombin or factor VII deficiency. The common sites involve the breast, buttock, and thighs. The pathogenesis is due to the procoagulant effects of the medication that may show in the first days of use. And this occurs because the natural anticoagulant protein CNS have a shorter half-life, and they have a faster decrease of their concentration than other factors involved in the procoagulation. So this transitory procoagulant-anticoagulant imbalance is exacerbated in patients who have protein CRS deficiency, leading to hypercoagulable state and thrombotic occlusions of the microvasculature, leading to these cutaneous lesions. Most will appear in areas of abundant subcutaneous tissue, and it's usually a well-defined painful macule that progresses to ecchymosis and then to necrotic tissue. The diagnosis is clinical, and then histopathology can help confirm the diagnosis. But once you see the necrosis, the treatment is with heparin, along with vitamin K to restore the levels of protein CNS. And then you discontinue the warfarin. However, this has not really changed the outcome. So good results are often obtained by essentially reintroducing the low-dose warfarin associated with anticoagulation with heparin at the same time. This is why we bridge with Lovenox in patients. So just moving on, this is a 47-year-old, this is a picture of a 47-year-old Korean man who presented with a complaint of itchy skin rash over his entire body. He had been taking antipsychotic drugs, including quetiapine, aripiprazole, and risperidone for schizoaffective disorder, and then he had lamotrigine added 3 weeks before the outbreak of his rash. On blood work, he had eosinophilia as well as elevated liver enzymes. So this is an example of DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms, also called drug hypersensitivity syndrome, and it's a severe adverse drug reaction characterized by fever, rash, and solid organ involvement. Now, it's classically discussed in the setting of anti-epileptics and occurs from anywhere from 1 in 1,000 to 1 in 10,000 uses of the aromatic epileptics, such as phenytoin, carbamazepine, phenobarb, primidone, and lamotrigine. Literature also supports including oxcarbazepine and Keppra, I'm just going to say, as causative anti-epileptics, and then also sulfonamides. Data does suggest a genetic defect in drug metabolism in Northern Europeans and Japanese, and those with the presence of the HLA-A3101 allele significantly increases this risk. First-degree relatives have a 25% risk of developing this syndrome. So I just want to show you this picture here because this actually does come up and is important to understand when discussing the different anti-epileptics. So DRESS will occur within the first 2 months of therapy and is really not related to drug dose or serum concentration. The pathophysiology relates to the accumulation of this reactive arine oxide metabolite resulted from decreased epoxide hydrolase enzyme activity. And these metabolites can cause cell necrosis, but also form neoantigens, which trigger T-cell mediated delayed type 4 hypersensitivity reactions. Fever and rash are the most common symptoms, and later the rash becomes edematous, and facial edema is actually a hallmark of this syndrome. Half the patients will have hepatitis, nephritis, vasculitis, and CNS involvement, such as aseptic meningitis, and then thyroid as well. And then hepatic involvement, maybe fulminant, is actually the most common cause of death in patients who have DRESS syndrome, with fatality rates of about 10%. The treatment is drug discontinuation, high-dose IV steroids, and then there is a 90% cross-reactivity to other aromatic anti-epileptics. So if someone needs an anti-epileptic, you have to choose a non-aromatic anti-epileptic. So let's conclude our talk with some historical examples, which are targets for board question in my recollection. So the first one that I want to talk about is eosinophilia myalgia syndrome. So in October 1989, the State Health Department of New Mexico was notified of 3 patients with an unexplained acute illness characterized by intense myalgia and eosinophilia. Each patient had been ingesting a medication for insomnia. Within weeks, there was a nationwide outbreak of the disease. Term eosinophilia myalgia syndrome was recognized. And then case control studies confirmed an unequivocal epidemiologic association between the syndrome and the use of a certain medication. By August 1990, there were like 1,500 cases that had been reported to the CDC, and it was suggested the actual number may be considerably higher. 85% of patients affected developed symptoms between July 1989 and February of 1990. 1/3 of these required a hospitalization, and there were 27 deaths attributed to this. So what is the implicated medication in the syndrome? It was L-tryptophan. So the early phase of the syndrome was characterized by intense myalgia, various skin rashes, edema, dyspnea, and then constitutional symptoms. Now, despite the discontinuation of the L-tryptophan, a substantial portion of patients developed a protracted course that was dominated by manifestations of cutaneous and neuromuscular involvement. Approximately half the patients developed a diffuse scleroderma, like cutaneous induration, and then histopath exam showed full thickness skin biopsies in these cases actually showed marked thickening of the fascia and dermis caused by accumulation of collagen and inflammation. Patients also developed a diffuse peripheral neuropathy, which progressed in the first year of the illness and was the most common form of neurologic dysfunction. So in May, and that was that syndrome. The next one was something called toxic oil syndrome. Now, in May 1981, there were the first cases of what would be later called the toxic oil syndrome that occurred in Spain and surrounding suburbs in Madrid. Hundreds and later thousands of individuals developed this acute mycoplasma-like pneumonitis. Most patients recovered, but then a couple, like 2 to 3% of patients died of acute respiratory insufficiency. And then this rapid onset and clustered pattern made an infection seem likely, but it was soon apparent that this was not the case. What was the implicated toxin in toxic oil syndrome? It was rapeseed oil. There was a careful case control epidemiologic study that established that all patients with the syndrome had ingested varying quantities of an industrial oil called rapeseed oil that actually had been marketed as olive oil. Rapeseed oil is required by Spanish law to be denatured with 2% aniline. And some distributors of olive oil took this rapeseed oil, removed the aniline by denaturing it, and mixed it in with other seed oils or olive oils. The oil was then sold as olive oil by vendors at a cheaper price. Within 1 to 2 weeks or sometimes longer, the ingestion of this oil, the patients developed the syndrome. Now, it's interesting, although the temporal sequence and geographic distribution incriminating the oil made this the likely cause, not all patients who ingested the oil became ill. And then furthermore, the syndrome has never been reproduced in experimental animal models. Once the cause was believed to be established, all the illegally marketed oil was removed by the Spanish government. However, by this time, the illness had reached epidemic proportions, and there were more than 20,000 patients that were affected, with more than 200 deaths. And if this was not tragic enough, it actually became apparent that there was a second phase of this illness that followed. So many of the patients who at first only had a mild pneumonitis returned to the hospital with signs and symptoms of a collagen vascular disease-like illness like scleroderma. They had widespread and progressive myalgias that were crippling, and they started to lose muscle mass and cutaneous sensation. Their exanthems became sclerotic, and their skin looked like sclerodermoid skin. They had dry mucous membranes, they lost their hair, and then many patients, perhaps as many as 10%, with the initial illness developed neurologic abnormalities that were so severe that they needed rehabilitation and custodial care. Here's a map of the distribution of Spain. This toxin is also associated with scleroderma-like skin changes. Spinal chloride, there's a picture there. And then finally, I think this is the last one that we're going to talk about, is a disease called Yusho, a strange disease, which means oil disease in Japanese. There was a Yusho study group that gave it the term due to food poisoning caused by the ingestion of rice bran oil. This was first reported in the late 1960s in October in the western part of Japan. And Yusho was initially reported as an unusual disease characterized by acne-like eruptions, skin pigmentation, and increased eye discharge. There are some epidemiologic studies that demonstrated increased rate of schizophrenia, as well as orthostatic hypotension, hypohidrosis, anxiety, or a variety of other syndromes and issues associated with this. What was the implicated toxin in the Yusho disaster? It was PCBs that contaminated the rice oil and heat exchangers during the production of the oil that were originally identified as the cause of Yusho. In the late 1970s, it was found that the rice bran oil was contaminated not only with PCBs, but also various dioxins and dioxin-like compounds. And that concludes my presentation on dermatologic toxicity. Thank you so much.